An understanding of risk is now widely recognized as a critical component to optimum treatment planning. This video explores oral disease risk and how it can be used in clinical practice. The need for risk assessment is now widely recognized. For example, the American Academy of Pediatrics recommends that all children should be risk assessed for caries at an early age. The American Academy of Periodontology has the view that risk assessment for periodontal disease will become a standard of care incorporated into all comprehensive and periodic oral evaluations and examinations. So what is risk? Well, defining risk is pretty straightforward. It's the possibility of an adverse outcome. For oral disease, the endpoint adverse outcome can be measured by the number of teeth lost due to the disease process, whether from caries or periodontal disease, and for oral cancer, the probability of cancerous lesions developing. The level of risk for an individual is a function of how many risk factors the individual possesses. Some of those risk factors can be biochemical, for example, genetic markers. Others can be behavioral, as would be the case for a diabetic smoker in the risk for periodontal disease. Factors can enhance risk of an adverse outcome, for example, diabetes, or they can reduce risk of an adverse outcome, as would be the case when a diabetic individual effectively controls their blood sugar levels. One way to think about disease risk is as an additional dimension of information that may not currently be included in the treatment planning process. Typically, we can think about diagnosis involving the evaluation by the clinician of patient history and current clinical conditions. To illustrate this, let's consider three separate patients who come in for an appointment. For patients with the same history and clinical state, a similar diagnosis might be made, with a common treatment plan for all looking like the right one. However, it frequently happens that results for the three patients are different. So a natural question is, why? If we open up the diagnostic process to a third dimension of risk, we find the answer. Individuals that looked the same, in fact, have different risk characteristics that may require different treatment plans. Patients with a given level of severity at lower risk may need less aggressive treatment, while those at higher risk, more aggressive treatment, even when the current history and clinical conditions for the patients are the same. In other words, without an understanding of disease risk, arriving at the right treatment plan is very difficult or impossible to do. To understand how to use risk to fine-tune treatment planning, it's helpful to think about the question by first stratifying the typical dental practice population into diagnostic categories ranging from health to severe periodontal disease. Again, this might be thought of as a two-dimensional view of the patient population, where patients with the same medical and dental history and the same clinical conditions would be grouped into the same diagnostic category, and would then logically receive very similar treatment plans. Based on provisor research, about 520 patients per 1,000 have periodontitis and need active therapy. However, the type of active therapy patients with periodontitis actually need is impacted by their relative risk of the disease state worsening. And even for healthy patients or those with gingivitis, if we don't know what their risk is, we really don't have the ability to fine-tune a preventive plan or recall frequency without quantifiable risk information. If we look at the same population by considering the third dimension of risk, we see that patients with the same severity can have very different risk characteristics. And we can see the impact of risk on tooth loss for patients at different levels of risk, regardless of initial severity. In a study published in JADA in May of 2002 by Provisor, the percentage of teeth lost over a 15-year period for patients who received routine dental care but not specific periodontal therapy could be determined. In that study, patients with a Provisor risk score of 2 lost 1 tooth in a 28-tooth dentition over the 15 years. For risk 3, the study population lost 2.25 teeth, and for risk 4, 3.5 teeth. For risk score of 5, which is very high risk, the population lost 6.5 teeth of a 28-tooth dentition. The important takeaway from this data is that if you can't quantify the oral disease risk for a patient, you really don't have an effective way of arriving at exactly the right treatment plan for that patient. There are many practical ways of using the clinically valid risk scores generated by the Provisor-powered CREST Oral-B Care Compass or Provisor's Oral Health Information Suite. Some of the most important include adjusting the recall frequency of patients at different risk levels. When considering whether to use locally applied antimicrobials on specific pockets, knowledge of the individual's risk of deterioration can be helpful in weighing the cost-benefit of these adjunctive therapies. For offices using laser therapy, a patient may, on the basis of understanding their relative risk of disease progression, opt for the laser-assisted therapy rather than mechanical procedures. Finally, and perhaps most importantly, when patients understand that risk coupled with untreated disease equals tooth loss, those patients are likely to become more compliant, more loyal, and more willing to take managing their oral health seriously than patients without that information. The Care Compass or Oral Health Information Suite will ensure that you and your patients have all the information needed to make the best choices among oral health care options.